Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Thank you for joining us. This is Billy Joe Mullinax here. I'm one of the Interventional Cardiology Fellows at Emory and one of the two co-chairs for this PERT and CardioNerds PE collaboration series. Before we get into this episode, I'd like to take a moment to give a disclaimer that we recorded this episode before the 2026 ACC AHA Pulmonary Embolism Guidelines were released. So there, we're pretty heavily focused in the 2019 ESC Guidelines. The new ACC AHA PE clinical categories triages PE on a scale of A to E, with A being the lowest risk and E being the highest risk. Specifically, A was noted to be the subclinical and incidental asymptomatic PEs, B being symptomatic with a low clinical severity score, and they triage that down into B1 and B2 between segmental and non-segmental PEs. C's were symptomatic just like B's, but they had an elevated clinical severity score, and they further triage that into 1, 2, and 3, and they give a respiratory modifier. C1 were normal RV function and size, as well as normal biomarkers. C2, they have to have an abnormal right ventricle or one abnormal biomarker. C3 was abnormal right ventricle and at least one abnormal biomarker. And then the respiratory modifier was if they have an SpO2 less than 90%, a respiratory rate greater than 30, and need supplemental O2. Clinical category D was incipient cardiopulmonary failure, with then a further categorization of D1 and D2. D1 was transient hypotension, and D2 was normotensive shock. And then the respiratory modifier for clinical category D is if they need greater than or equal to at least 6 liters of nasal cannula or a non-rebreather mask, which brings us into category E, or cardiopulmonary failure. They stratify that into E1 and E2, with E1 being recurrent or persistent hypotension with shock, cardiogenic shock, and E2 being refractory shock or arrest. And then the respiratory modifier for that is persistent hypoxic respiratory failure or ventilator failure. So that is the difference that's in the new ACC 2026 Pulmonary Embolism Guidelines. Don't worry though, we're going to spend an entire episode diving into these new guidelines very soon. And we're going to do that with the chair of the guidelines, Dr. Mark Krieger. Until then, thank you for joining us, and we're going to return to your previously scheduled broadcast.
Hello, CardioNerds, and welcome back for another episode in our Pulmonary Embolism series. This is Billy Joe Mullinax. I'm one of the Interventional Cardiology Fellows at Emory University in Atlanta and a member of the PERT Consortium Training Council. We have an incredibly important episode today. We're diving into one of the most nuanced decisions we make in acute care with respect to pulmonary embolism, specifically the risk stratification in acute pulmonary embolism. Who needs the ICU? Who can go home? And who sits in the dangerous gray zone where the next move could be anticoagulation, early reperfusion? To help us break it all down, I'll kick it off by introducing our team. We have my co-chair and good friend, Dr. Dinu Balanescu. Dinu is a cardiology fellow and incoming interventional cardiology fellow at the Mayo Clinic in Rochester, Minnesota, and a member of the PERT Training Council. Dinu, really good to talk to you again. Take it away.
Thank you, Billy Joe. It's always a pleasure. You know, in the cath lab, things are often binary. The vessel is either open or closed. But in the PE world, especially when we're addressing risk stratification and reperfusion therapies, there's constant nuance. So to help us navigate this, I'm thrilled to introduce today's episode lead, my good friend, Dr. Jane Ehret. Jane is a pulmonary and critical care fellow at the University of Vermont and my co-chair in the PERT Training Council. Welcome, Jane.
Thanks so much, Billy Joe and Dinu. I'm thrilled to be here and to dive into PE risk stratification today. We have an absolute giant in the field here with us today. He arguably wrote the book, or at least the guidelines, on this topic. It is my distinct honor to introduce Dr. Stavros Konstantinides. Dr. Konstantinides is medical director of the Center of Thrombosis and Hemostasis at the University Medical Center in Mainz, Germany, and professor of cardiology at the Democritus University of Thrace in Greece. He served as the task force chairman for the 2019 ESC Guidelines on the diagnosis and management of acute pulmonary embolism, which essentially redefined how we categorize and treat this disease globally. Dr. Konstantinides, thank you so much for joining us.
Thank you very much, Jane. Thank you very much, Dino and Billy Joe. Thank you for your kind words. I do not deserve them. I do not believe in single giants, or I just believe in teams like the task force you mentioned that have done their best to help to advance the field. And there are many on either side of the Atlantic and in many places in the world. And it's a great pleasure and it's an honor for me to be with you because this is exactly the topic that you chose is, I would say, the hottest topic in PE. As Dino very nicely said, there are interventions and they help a lot. But in order to get the most out of them and make the right decisions, you have to know who is at risk and how do we exactly judge who is at risk and who may be at risk in a few hours or minutes. So I'm very happy that we have this topic to talk on today.
Dr. Konstantinides, let's start with a case from the CardioNerds emergency room. We have Miss Gray Aria, a 65-year-old female who presents to the ED with acute dyspnea and pleuritic chest pain. Her medical history includes mild COPD and remote breast cancer in remission. Her vitals on arrival are a heart rate of 118, blood pressure 116/68, respiratory rate of 26, and she's saturating 88% on room air, which improves to 94% on 4 liters nasal cannula. She appears distressed with mildly increased work of breathing at rest. Labs are notable for a high sensitivity troponin of 0.09 nanograms per milliliter, which is above the upper reference of normal, and T-proBNP of 14,000 picograms per milliliter, which is elevated, and a lactic acid of 3.1 millimoles per liter. EKG shows sinus tachycardia and a new incomplete right bundle branch block. Echocardiogram in the ED showed a dilated RV with a TAPC of 12, an estimated RV to LV ratio of 1.2, moderate RV hypokinesis. A CTPE is done and it shows a bilateral pulmonary embolism in the main left and right pulmonary arteries without a saddle component. RV-LV ratio was 1.3, and there was contrast reflux into the IVC and hepatic veins. She started on enoxaparin. Dr. Konstantinides, can you walk us through how the 2019 ESC Guidelines transformed our thinking from massive submassive to a risk-based approach? And why is a stable blood pressure not enough to call a patient low risk, and where does our patient fall in terms of risk category?
Thank you very much, Jane. This is really a very interesting case. And so the question is, as you very nicely said, what is the risk of this patient in the next hours or minutes? Let's start a little bit with the history, with the historical perspective. What did massive submassive mean 30, 40 years ago? Well, when the first studies on what we call advanced reperfusion treatment in PE started, that was in the early 70s already, and speaking of systemic thrombolysis or fibrinolysis, at this time initially with urokinase and streptokinase. Well, what people did was, okay, let's test how these drugs are working. And the way they tested that was to see how much the angiogram improved. So how abnormal were the findings in the pulmonary angiogram before the treatment and how it was after treatment, how it improved. So massive PE was something that very much depended, or it implied that it depended very much on how big and how spread the thrombi were. So it was a little bit some kind of morphological definition. And of course, massive also defined the patients that were in shock. Okay, so submassive was something that came later, and submassive was meant to indicate, to point to patients who did not come into the massive category in terms of hemodynamic collapse or of huge thrombi everywhere, but somehow, and this was the era when we started looking at the right ventricle and what right ventricular dysfunction is, or a large right ventricle compared to the left ventricle, how much this was abnormal. So it was one step below. And then there was the non-massive PE. So this was okay. People understood, so many clinicians understood what it meant, but it was not exactly what we wanted to say, right? The important thing was for educational purposes and for standardization purposes, for better communication and for better decisions, to agree on what are the criteria that define a patient who needs some more advanced therapy, a patient who is fine with anticoagulation alone, and as you said, a patient who may even go home early and be treated at home. So what the ESC guidelines proposed was to speak of high risk, intermediate risk, and low risk PE. So we left this term massive, which always implies, a big mass, so implies large thrombi, because of course large and central thrombi are important, but they are not perhaps the main determinant of what the risk of the patient is, and try to define criteria of high, intermediate, and low risk, right? So high risk was what perhaps mostly correlated to massive in the past. So these were the patients with what we call hemodynamic instability and shock, cardiogenic shock or obstructive shock, as some people call it in the case of PE. And intermediate risk were the group of patients who did not fulfill the instability criteria, but what they did have was some right ventricular dysfunction. And the patients who had neither instability clinically nor right ventricular dysfunction were at low risk. Now, what we see in this case, and that is where does our patient fall into? Now, first of all, does this patient have high risk PE? Well, that's quite difficult to say right now because this is a patient, and how do we judge this, right? I mean, the patient has right ventricular dysfunction. We see that from the TAPSE, we see that based on the RV-LV ratio, and we see that based on the cardiac biomarkers, the NT-proBNP, for example, and this high sensitivity troponin. So this patient clearly is either at intermediate risk or at high risk PE. What is she of the two? Now, one could say that, well, blood pressure is okay, 116 to 68. She is tachycardic and she is hypoxemic. And well, one could say, okay, since she does not have a low blood pressure or she has not collapsed yet or does not need high dose catecholamine, the patient has so-called stable blood pressure, so she would not be in the high risk category, she would be in the intermediate risk category, typical stable blood pressure, but RV is not okay, RV is dysfunctioning, and there are signs of right ventricular failure just by the NT-proBNP levels, and also there's some myocardial injury and necrosis based on the troponin levels. Now, here is, however, what we need to discuss today and what we are here to discuss today. This patient has, on one hand, the criteria of right ventricular dysfunction, and she has criteria based on her vital parameters that show that she is in distress, right? She is tachycardic, she has a borderline blood pressure, she is not overtly hypotensive, but she also has something that is important when classifying the patients. The patient has an elevated lactate level, right? And this also means that the patient is hypoxic. She is hypoxemic and she's also hypoxic. So I would say in this case, based on somehow expanded and interpreted criteria of the ESC guidelines, that this patient is, well, let's say at the border between intermediate and high risk PE. So this is what we call intermediate high level, or let's say at least this patient is really at a risk that is high enough, first of all, to warrant treatment in the hospital. There's no doubt about that. To warrant some monitoring that will be important at an intensive care or intermediate care unit. And then, of course, discussion. We will talk about that of the PERT on how to proceed now, if heparin alone is sufficient or if we should do something more.
Wow, Dr. Konstantinides, fantastic run through. And honestly, you had my wheels spinning a lot there with so many other ways to come off because you really hit on a lot of things that I hoped we were going to talk about today. You jumped into some of the subtleties, even within what we've gotten into what looks like a relatively nice risk stratification model based on both lab work as well as the clot burden and the vital signs particularly. But even within our model, you suggested it yourself, in our intermediate high, some of those patients are a little bit higher risk than others and vice versa. Right? We've definitely seen those examples of people with COPD and chronic hypoxic respiratory failure and already some baseline RV dysfunction coming in with some serology elevations based on a COPD exacerbation. And they could, with a small PE, stratify higher, even though we know they're not there. But you're suggesting this patient may be on the higher risk side. And even within our high risk category, we could break that down into catastrophic and non-catastrophic. So that was really fantastic. And thank you so much I'm curious how you feel about some of the legacy risk scores. You didn't mention them at all, and I rarely use them as well, but we know that if we were to calculate Miss Gray's SPECI, she's going to get points just based on her age and heart rate, but it doesn't really tell us how close she is to falling off that cliff. How far is she from intermediate high to high? In your view, what are the limitations of those risk scores when trying to decide on escalation of care rather than just discharge, and do you even use them at all?
Yes, thank you, Billy Joe. That's a very important point. So, where are we with those legacy scores, the way you call them? We have the PESI that everyone knows. This is a great score. The PESI score was developed and validated by Drahomir Alžeski about 15 years ago, almost 20 years ago. And it was a score which was designed to give an estimate of the patient's 30-day mortality risk in the acute phase. So this was not a score for making therapeutic decisions fast and early, but it had a great advantage. It integrated comorbidity, which is important because two patients with the same severity of PE may have a totally different outcome depending on their underlying disease and their comorbidities are, so that's really important. And it also integrated some of the vital parameters, right? And so it integrated the blood pressure, heart rate, and so on, and the hypoxemia. So that was good. But what the PESI did not do, and also all the other scores, the BOVA score and so on, did not do, is that they were static scores. So you were supposed to, determine the score once and say, these are the vital signs now at this time point DT, the way I see them. These are the patient's comorbidities, which, okay, they are here. They do not change every minute. And the PESI score itself said nothing about the right ventricle. BOVA score integrated that. But it was more or less an instantaneous snapshot, which would give you a general idea that the patient's mortality risk is in the acute phase. But what we need, and what the ESC guidelines partly did, but what is becoming better as we speak, and I hope that we will have more progress into that with the new AHA, ACC guidelines, and hopefully with the new ESC guidelines 27, is, we need a score that will help us to dynamically, assess how the patient's situation is evolving. When we say the blood pressure is stable, right? What is stable? Stable means that it's not moving. So we need serial assessments. And there comes the question, what shall we assess? And we have some parameters that are here for quite a long time. That will be, let's say, the thrombus load. It will not change within a couple of minutes or hours. The patient's right ventricular pressure overload will not change over a couple of minutes or hours, but what may change are the vital parameters of the patient. What may change are the lactate levels, for example. And this is what we must use to monitor the patient's condition. And this is what the PERT will have to take into account, because the PERT will convene and judge what the patient's condition is. But the PERT may have to reconvene and see we decided, for example, to go on with heparin, but how many hours later do we have to talk again and see, was that successful, or is the patient deteriorating, or is the patient simply not improving? So we need some more flexible, some more dynamic assessment of the patient's status, which these legacy scores were never designed to provide. So we cannot ask from scores more than they were designed to give us.
Dr. Konstantinides, that is such an eye-opening perspective, and we'll touch on dynamic risk assessment and what the future holds a little later in the episode. But for now, I'd like to acknowledge the inherent limitations of each of our current scores and how they may serve distinct roles as well. So it's important to note the distinction between predicting mortality versus predicting hemodynamic collapse. And Jane, you actually led a study to address this gap. So you proposed the PEP score, the Pulmonary Embolism Progression Score. So shameless plug, look up Jane's publication on this. Now, going back to some of the limitations of these scores, we generally accept that an abnormal biomarker in PE is bad, but this is a binary assessment, and current data mainly supports this qualitative rather than quantitative approach. So there are limited data on the correlation between the absolute value of biomarkers and actual risk. Now, for example, in the ESC 2019 guidelines, You specifically note a cutoff of 600 for NT-proBNP, if memory serves right, and acknowledge how that's based on limited data. And a patient with a troponin of 0.09, for example, and an NT-proBNP of 1,000 may fall under the exact same risk category as a patient with a trope of 0.5 and an NT-proBNP of 3,000. On top of that, lactic acid assessment, which is a well-recognized parameter of cardiogenic shock severity, is not included in the ESC risk stratification paradigm. So, Dr. Konstantinides, how do we interpret a mildly elevated biomarker compared to a markedly abnormal value? What's the role of serum lactic acid, and how does this interpretation change our approach to risk stratification?
Yes, Dino, that was really beautiful because what you did was to exactly point out where the weaknesses and limitations of the existing risk stratification schemes are, like the one that was developed by the ESC. I mean, at some time point, we try to make a suggestion on how to risk stratify patients based on what we know, what to the best of our knowledge at this particular time point. Now, 6 years later, things have moved on, and we have to move on as well. It's as you said. I mean, first of all, of course, we know that that's how we learn many things in medicine. I mean, although most human parameters are continuous, we love cutoffs, right? We want to know, so above this cutoff, things are bad, below the cutoff, things are good, or vice versa. And this is, of course, something we do for educational purposes or because our mindset is such that we love this kind of thing. So this is black and this is white. So things are not like that. So what we have not done thus far is really to have, I mean, we are doing it in clinical practice, of course. The nurses are doing it, the MDs are doing it in ICUs, in CCUs. I mean, you are watching the patient's condition and you can make a judgment on whether this is deteriorating, your therapy is working, or your therapy is not working. But we don't have this in guidelines yet. And these are some of the problems you highlighted. First of all, what is mentioned in the guidelines is, for example, the PESI, with what we discussed. I mean, nice score, but static score. It's not something that helps you see if the patient is getting closer to collapse or not. Even the Hestia score, I mean, good score for someone who does not appear very sick on whether they can be sent home, but of course not for monitoring the patient's condition. And then we relied, perhaps retrospectively, one could say we relied too much on biomarkers, which are quite important to see or to once in the acute phase, like the NT-proBNP or the troponins. But the dynamics of these biomarkers over the first hours are not so important for our decision. So what we need, what do we need? What we need, as I said again, because I'm meanwhile convinced that this is quite simple, we need the dynamics of the vital parameters, so blood pressure, heart rate, oxygen saturation, typically. And what we need is something that the rest of cardiology, I think, is coming closer to, with the SKY definition of shock and of the different levels of shock, is we need parameters of hypoxia, not only hypoxemia or blood pressure, but parameters of tissue perfusion that is not okay, that is diminishing, that is worsening. And the lactate levels, this is such an old biomarker, but it's really so useful. It was, as you pointed out, and I'm really very sorry for that retrospectively, unfortunately not included in the ESC guidelines. And this is something that can tell us, not alone, but taken together with all other markers, clinical imaging, what we have, it can tell us what is the patient's condition at this time point and how it will be in 2 hours, 3 hours, 24 hours from now. So, in my opinion, what we will need, what we are implicitly doing and instinctively doing in our everyday practice, but what will have to be somehow sanctioned by future guidelines will be this monitoring of the patients and being based more, not just on some cutoff levels of troponins or NT-proBNP. This is useful to know, but that's it, right? It does not help you within the next hours. What we need is a tool that will help us say, okay, I decided to start with therapy A, and now 4 hours, 8 hours later, I see that my patient is deteriorating, is getting worse. Based on this worsening of this score, now my patient needs to be treated differently.
Going back to Miss Gray, she is normotensive, but she has RV dysfunction and elevated biomarkers. She's intermediate high risk going by the ESC criteria. And as we just discussed, we cannot look at just a single blood pressure reading and call the patient quote unquote stable. So, Dr. Konstantinides, can you walk listeners through the clinical variables that matter most at presentation and what predicts early hemodynamic collapse versus 30-day mortality?
Well, that's a nice continuation of what we were saying. So, if we would talk about 30-day mortality, we would say, right now, this is her blood pressure, this is her heart rate, this is her saturation. She would get a couple of several points in the, let's say, PESI or SPESI scale, and that would be a patient who would have quite a high risk of early mortality. This risk might be 5%, 10%, 15%, or even more. But of course, again, this is something which is of nice academic relevance, but it is not something that will help us now on how to guide our decision. I think the parameters that we have to take into account here are, so the patient's blood pressure, as you said, she is normotensive, at least she formally is more normotensive, but we know, the blood pressure is the last line of defense, right? I mean, it's the last to collapse and go down. So heart rate is high. She also has hypoxemia and she has high tissue and organ hypoxia, as we can see by her lactate. So she has clinical signs that are very close to the red zone, if they are not in the red zone already. I mean, if we had, and maybe we will have in the future, a SCAI classification of shock also for PE, that would be, I think, in a between threatening and already beginning shock. On the other hand, what she also has, and what also will tell us what the patient's risk is the right ventricular dysfunction, which she obviously has. And as I said, the more static biomarkers, troponins and T-proBNP. I mean, they're not static over long periods, but right now they would be, now we know them. We don't need to monitor them every few hours. And based on data from the real world, one would say that this patient's risk of dying in the next hours or days or in hospital if we do not perform advanced therapy would be at least 15%. Here is something that I would like to say. When we are doing trials, I mean, there are many trials, as you know, with catheter-directed treatment going on, and everyone says, well, mortality was very low. These were not really high-risk patients. Of course, we have to choose correctly the patients that have to be candidates for such treatment that are also included in trials. And these criteria can no longer be the ESC criteria alone, so just an RV-LV ratio, which is a little higher than 1 and some troponin level, which is marginally elevated, but they also have to be enriched criteria, like the ones that are being used, for example, in the HI-PEITHO study, which will be presented presumably quite shortly. And so this is one thing, but what we also need to know is that trials are designed in such a way that, of course, an intervention, even if it has to be on an emergency basis, is guaranteed. So we do not let patients die. We are very cautious in trials. But if we take real-world data from registries, I mean, a patient like Mrs. Gray would be someone who would have, I would say, at least 15% risk of death in hospital based on the condition she is in now. And that is very high, right? That is much higher than the risk of death of a patient with STEMI in hospital, a patient who has made it to the hospital. And exactly as we need to take action and do some advanced therapy for STEMI, we've known that for almost 30 years, the PCI that's being done in the cases of STEMI, and we know of advanced treatment for stroke. There are categories of PE patients, risk categories, not all PE patients, of course, but risk categories in whom anticoagulation alone is not enough. And this is, in my opinion, a typical patient for whom the PERT has to convene as fast as possible, and they have to decide, depending also on what their hospital has to offer, what resources, what expertise there is in the hospital, on how to deal with this patient as fast as possible, how to treat her. Because as I said, based on the patient's vitals, based on the patient's lactate levels, I think she's very high in the intermediate risk zone, or I would say low in the high risk zone.
It's really humbling to realize that a patient that we quote as hemodynamically stable actually has a risk of in-hospital mortality as high as 15%. That's just huge. And this actually reminds me of an emerging concept in the cardiogenic shock world, normotensive shock. And this is especially important in the PE phenotype of cardiogenic shock. We're seeing more data on the composite PE shock score, the CPES, that was derived from the FLASH registry data. So, Dr. Konstantinides, can you please explain the concept of normotensive shock in PE and how can a patient be in shock with a normal blood pressure, and how does the CPES score help us identify these patients?
Yes, that's exactly the point. I mean, to be honest, I think the whole term normotensive is a wrong thing. Normal blood pressure and high and low blood pressures were, of course, work very nicely, in chronically ill patients, that. But in acute care medicine, right? The question is, as I said, I mean, when you look at the spiral of hemodynamic deterioration and collapse ultimately on patients with acute PE, for example. It could be acute myocarditis, could be acute STEMI, whatever. So if you look at this, then of course the fall in blood pressure into hypotensive levels will be the last part of the spiral, and probably when things are too late. So what you need is identify the patient at risk of hypoxia or acute circulatory failure, I would call it, as early as possible. And this is the idea of normotensive shock. What I really like about this emerging classification and about the reintroduction of lactates and about also a new score that will also, like the one derived from the FLASH registry, that will let us integrate the information we have, the imaging, the laboratory, the clinical data. And the good thing about this is that we go away from what we read as blood pressure right now as the main criterion on how to decide. When blood pressure falls, it may already be too late. And normotensive shock is what this patient has right now. I mean, this is a patient who is hypoxic. This is a patient with rising lactate levels. She's well above 3. And of course, the lactate levels will have to be monitored, something that we've done and we are doing in ICUs. I've spent quite a long time of my career in a medical ICU. And I mean, we were doing that, right, back in the past millennium in the 90s. It's still what one has to do. So normotensive shock, I do not very much like the term, but it is correct in the sense that it tells you that you may be in shock, so you may be in high risk, and you may be at imminent risk of collapsing and dying, although your blood pressure seems to be normal. And that's exactly what we have to do. We have to go away from the old scores, those instantaneous snapshots of some parameters that will tell you what will happen within the next 30 days. I want to know what will happen within the next few hours. And this is what these new scores help us to do, based on the course of the patient's vital parameters.
Really fantastic. And Dr. Konstantinides, you are starting to hint at a lot of the things we are excited to share with our CardioNerds listeners about with respect to escalation of care, ICU, transition from catheter-based therapy to TPA, ECMO. We got all those things coming, and we're looking forward to you guys hearing them. We mentioned a lot of abbreviations and various scores today, and it's kind of the nuance in our triage, both within the intermediate risk and even hinted at some of the nuance within the high-risk patients. I am curious how you would specifically suggest us, as clinicians to modify our thinking. Obviously, I think part of your answer is going to be to look at more dynamic measures, reevaluate the patient, more constant communication with whether our ED colleagues or ICU colleagues if things change with respect to which therapies to offer. So kind of as a parting thought on this to nail it down, what would you say with respect to these scores when it comes into their future guideline recommendations? How do you think they're going to integrate that moving target of vital signs and patient stability over time?
Yes, I think let's take it a little bit from the bottom-up approach. I think this is something, so before going to the guidelines, what I would say is that these are things, as I said, that are being done in clinical practice, in ICUs, in CCUs. I mean, that's the reason why you're being monitored, right, in an elevated care unit. I mean, what is being done is that there are protocols. I mean, nurses have excellent experience with this on how frequently your vitals are monitored, how frequently some other important laboratory parameters like lactate is monitored, and then, of course, you can judge this. And this is how actually the introduction of PERT, of these multidisciplinary teams, has helped or is helping to standardize this in PE care as well. I mean, PERT, it's not something to continue our old thinking with the PESI or BOVA or whatever, or the EOC model on what is intermediate, high, or low. I mean, PERT gets together, sees a patient like Mrs. Gray here. So here the PERT would probably say in a major referral hospital, we must choose a catheter intervention to help this patient or systemic fibrinolysis, depending on what is available, what they believe. Or they may say, okay, let's wait a couple of hours on heparin alone. But what must be important and what must be implemented, and actually this is what the PERT structure is about. It's about having activation protocols, so who comes into question for being seen from the PERT, and also protocols or factors on which to decide. And here the PERT you can use the CPES score, you can use the PEP score. I mean, this is something that the PERT can decide locally. And then there must be, of course, a protocol on when to monitor the situation again, or when to go back to the nursing staff or the ICU physicians and ask for the patient's course over the past hours. So these protocols should be working already. And I'm sure that they work like this in most hospitals. The PERT does not leave the patient alone after they have made a decision, because maybe 3 hours or 4 hours or 5 hours later, the decision is no longer the correct one and you need to revise. So now the guidelines, that's my opinion. That's what I expect and think. So I'm not trying to give up any secrets that I do not know myself, but I think the guidelines will need now to take up this change in paradigm that is happening, that has already happened, that is being implemented by PERT around the country and other countries of the world, and try to put it also in some more formal recommendations. In that case, I think however, that's the real life that will now tell the guidelines, now you have to act. We did not have it in the past. In the past, people came, many people were experts, but so people told clinicians, so this is the risk category of the patients. The doctor said, okay, now we heard from the guidelines, this patient fulfills the criteria of intermediate risk PE, and this is it. Well, this is it now, but maybe in half a day from now, it's different. So now we know with PERT and with the way PE is treated now in a more standardized way, in a more streamlined way in many hospitals, in an increasing number of hospitals, that we have to monitor the patient's condition. And I think now the guidelines will have to take this into account. The guidelines will scientifically validate all these scores that we were discussing, right? The CPES, the PEP, those new scores. They do not have a very solid body of evidence, or the new score that we are using in some studies already, and that is being used very frequently in the UK, in many European countries, which is a very simple course, vital signs-based score used by nursing and medical staff to see how the patient is doing. These scores may not have a very strong scientific background or evidence yet, so it may be a little bit more difficult for guidelines to have a recommendation, but it is about also to get this new thinking into the treatment of PE and actually sanction something that is already happening and is the right thing. And the registries that have been conducted, so not only the RCTs, but the registries that have been conducted, let's say, with one or the other device. You mentioned the flash registry, and many companies and device manufacturers have performed similar registries, and many of them are ongoing. I mean, they show in one way or the other, in similar ways, what is happening right now. And what is happening is this dynamic, this continuous monitoring of PE and the flexibility and the capacity to change your decision, escalate the treatment. But this has to be done, of course, not when one or the second or another physician arbitrarily thinks that's the right point. There must be some score, some standardized criteria to do that.
A lot of places activate a PERT team for intermediate risk or above. But with everything we've spoken about so far today, should all PE patients have a PERT activation to help with the risk stratification, in your opinion?
Thank you, Jane. That's a very good question because I think my answer can be quite clear. No, this is not necessary. So you need the PERT for patients. You need it. This is the very typical candidate. This patient, Mrs. Gray, is the very typical candidate for a PERT. So it has to be patients who have some risk factors, who are at least, let's put it still in the conventional way, at intermediate risk, or at least in the intermediate risk, if not at higher risk than that. This is one thing. Or they may be patients who may not have a very severe acute episode per se, but perhaps their comorbidity profile makes the situation very critical even with smaller PE. That's the minority of patients, but they also have to be taken into account. Based on our experience, I cannot tell you now this is the percentage, this is the proportion of patients with PE that need to be treated or seen by the PERT. In our experience, we have established PERT in my center. We did that in 2019, which was difficult because we had a COVID time immediately after that. So that was a little bit difficult then to compare. But I would say that about 15 to 20% of our PE patients are seen by the PERT. It may be 25% that is correct. I don't know. In any case, it's not the majority of the patients. Most patients are stable enough, are well enough to be managed with anticoagulation alone, and they will be fine. And in many cases, you can start with direct oral anticoagulants right from the beginning, and it's fine. But as soon as the patient shows some signs of increased risk, and we discussed what these are, at least one of the vital signs is not okay, or laboratory parameters, both the classical parameters like natriuretic peptides and troponins, but also the lactate, which we said, I mean, this is something that it's such an old marker, but it was missing from guidelines. And or if the imaging findings, either of the right ventricle or the findings of the pulmonary circulation suggest something which is very abnormal or, let's say, very extensive, so it's exactly something that integrates many pieces of information, then the PERT is called to see this patient. And this is also why we have in our institution, and I think most PERTs have in their protocol in the hospitals, there's also a gatekeeper, so you cannot have everyone, everyone with a little dyspnea being seen by the PERT. This is not necessary, but you will have to have someone who will decide on how to activate the PERT. That's what we do at least, and this is usually a doctor who has experience with acute care medicine, preferably more specifically with PE, and can tell first roughly, okay, this is a case that appears serious, let's call the PERT. He can do it generously. That does not have to filter out many patients.
One of the main buzzwords during today's discussion was dynamic, and we talked about how we rely heavily on these static scores and snapshots in time. The physiology can change at a moment's notice. So there's a lot of excitement around quantitative CT metrics, strain, new biomarkers, artificial intelligence models. So Dr. Konstantinides, looking ahead, what single development do you think will most transform PE risk stratification in the next 5 to 10 years? And do you envision future algorithms being continuous and dynamic rather than the categorical ones we have now?
I'll start with the second part, which I think is easier. I do believe that the risk stratification algorithms will be dynamic. I do believe that we will have to find an algorithm of testing and, let's say, having the criteria for testing, not instability, but testing for assessing deterioration of the patient. I think we have the main tools for that. We do not need some, because nowadays everyone dreams of having a multifunction tool based on 6,000 parameters that will give this information. I believe that we have the most important parameters already, and there are 6, 7, 8, 10 parameters, but not hundreds or thousands. And so I think this will happen. I do not know in this particular situation how much we will, let's say, AI developed algorithms will help. Well, AI will help perhaps in everything, but in my opinion, from what I can see right now is that AI helps, depict these patients among the patients entering the hospital and letting us know, for example, better than starting searching manually ourselves, which patient is really has a problem. It also is very helpful in, identifying instantly patients who may be good candidates for this or that study. But I think that we, in our practice until now, especially when we have to do with acute care medicine, we do not need, and I think this was the disadvantage and the main obstacle until now, you don't need ever more complicated scores or more difficult scores or scores having the largest number of parameters or the scores having, you need relatively simple things. I mean, in acute medicine, I hope you'll agree with me, we need to know some simple things, but we need to know these things now and to be able to make our decision now, because otherwise people die. I mean, things may be chronically more complicated, but there you have time to think and revise. So I think we have the ingredients to get the right algorithms. Maybe there is not one single right algorithm, but one single risk score. Doesn't have to be CPES or PEP, or maybe both are good, but we have the ingredients, and now we will have to test these ingredients and make sure that we will also provide the formal evidence that will help also guidelines, officially sanction them. So officially sanction something that is already being done in practice. And clinical trials, besides saying if this catheter approach is better than nothing or whatever, or comparing with each other, when they use, and this is what we try to do in some of the studies that are still ongoing, when they use such integrating or dynamic scores, clinical trials have a very nice positive side effect, namely also validating these scores, which again, I believe for everyday use and for fast decisions must be as simple as possible and not too complicated.
Before we close, here at CardioNerds, we ask all guest experts one final question. What makes your heart flutter about PE risk stratification?
Yes, I think what makes my heart flutter, I hope not arrhythmically, is the fact that, I have been working in that field of risk stratification of PE for really many years. And when I remember how we started, I can only think now how naive we were back then. We thought, if you find this parameter in echo, and it is above this value, then you found it. That is the patient who is at risk. And then we moved over initially from the size of thrombi to some data on the right ventricle. Then we went over to troponin or to BNP. There were also many other biomarkers that were tested. And all these things did not really help us much. They helped us with some good publications, but we did not develop a holistic, and most of all, we did not develop something which is dynamic risk pattern. And now I think we've reached a phase, also thanks to the progress, the technological progress. We have to say that, we have to acknowledge that the progress of catheter interventions that do help us also progress, in our thinking. Now we have reached a stage where this field is moving. And for the first time, it's moving not just in order to, have some more publications, but it's moving, in my opinion, in the sake of patients, because now what we do is from the perspective of what it will be now my decision based on what I just learned, or what the patient's course was over the past few hours or minutes. What do I choose from my therapeutic options, out of my therapeutic options right now, to help the patient? So now it's really patient oriented, not only in words, it is actually now patient oriented. So I think that we will be seeing really a true progress in the field of PE, something that will now be patient centered and will become more efficacious. So I'm very happy about this.
Fantastic. Thank you again to our CardioNerds listeners for joining us on this episode of this ongoing collaboration between CardioNerds and the PERT Consortium for our Pulmonary Embolism series. And to our listeners, risk stratification in PE isn't a one-time label, as we've so eloquently heard today. It's a living process. We watch the trajectory, reassess our patients often, and then we engage in the multidisciplinary team early so that we can have this as a patient-centered process. So thank you again for all of your time.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Joshua Khorsandi. I'm an intern in the CardioNerds Academy, House Taussig, and an undergraduate at the Johns Hopkins University. Check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and splits.